Hello everyone. We are live. It's always awkward because you guys don't see the behind the scenes. We're just kind of there and then we like pop up. So
I know I was typing and then I was like, oh, maybe this typing actually like sounds like it's a lunch and learn. It's a good like sound in the background.
yeah. So Liz, do you want to announce because this is a part
Yes.
two?
Good to see everyone. Thank y'all for joining. As always, for anyone who joins, please say hi, tell us who you are and where you're joining from. But of course, throughout today, please submit any questions that you have. A couple of our housekeeping reminders. This is not intended to replace therapy, but is intended to be educational. If you're feeling suicidal, unsafe, or in crisis, if you're local to the U.S., you can now call 988, but of course, follow your emergency resources locally wherever you are. I am so excited for us to be back together with both Chris and Dr. Abramowitz. We did this talk, what was it? Probably like 2 months ago now.
Feels forever ago,
Yeah, our forever ago, right? Our part one. But it was so awesome. And we were just like, we didn't get through half of what we got through. But for those of you who haven't watched, we will put the link in the comments so that you can watch section one. But it really, what we decided to do was figure out how we could help those of us living with OCD become the best consumers of treatment. And so this is part two of it. So part one is where we really covered a little bit. We got into like what makes something evidence-based. When we talk about ERP being an evidence-based treatment for OCD, what does that mean and what does it go through? And we'll get into a little bit more details around that today. But we really started to talk about the basics of like science and history around OCD and OCD treatment. And we're going to get to continue and, of course, answer questions along the way. So what our goal is that by the end of today, if you've watched part one and part two, you feel really comfortable understanding where do I start for OCD treatment? What questions should I ask? And also, I talked a lot about this today with a patient. What should you expect in treatment? When do you expect treatment outcomes to come to fruition? What does that look like? Those are all really important questions. So today we have lots of questions that we will start with and jump into part one where all three of us will chime in, but Dr. Abramowitz, with your scientific background, your research history, and all of your knowledge, thank you for being here because it is so helpful to all of our consumers.
It's a pleasure to be back. Thanks for having me. Always fun to converse with you guys.
Awesome. Yes, it is. So, okay, we'll jump in. So where we left off is we were talking a little bit about evidence-based care and what it means when we talk about evidence-based care. And we spent a little bit of time covering the science behind it, but also how we understand it for our diagnosis. So Chris, why don't you talk a little bit about just how we shared that, like, if you have a different diagnosis, ERP wouldn't be the evidence-based care, but like, how does someone navigate that? And can you kind of a general overview or sorry, Chris, I'm going to pause. Jon, why don't we start with you? Can you give a quick overview of what evidence-based care is? And then Chris, why don't you share how you would figure that out for a different diagnosis than OCD?
Sure. Evidence-based care, the idea is pretty simple. It's basically saying that we're going to use the best assessment and treatment methods that are based on the best available data and science, not just on anecdotal personal reports or personal experience, but actually going to the literature, looking at the science and applying that to what a person needs.
Yeah, and we talked a little bit about last time, Chris and I shared that, both of us live with OCD. And so both of us might feel like, well, we have a pretty good understanding. 10 years ago, I might have thought I have a pretty good understanding of OCD and OCD treatment. I've gone through it myself. I've lived with it. But the reality is that didn't make me equipped to treat it. It didn't make, right? My personal experience did not give me the education, the scientific background, the training and knowledge I would need to treat OCD, right? That is a different training. That's different expertise that we get. And so when we think about evidence-based care, it's not just, is someone a clinician? It's really like, are they a clinician? Do they specialize in the disorder you're suffering with? And do they understand what treatment has the best chance of being successful for you?
That's right. And I think it's really important to say that a person's personal experience, their lived experience is important. And we need to listen to that. And we certainly would never want to discount that. That's really important. And that said, it's not the same thing as scientific data. It's comparing apples to oranges. They're both, I love apples and I love oranges. They're both good fruits. They're both healthy for you, but they're different. And it's the same thing here. Evidence-based care means that we're going based on the science, not based on personal experience.
That's right. So Chris, tell us if I'm let's say I come to your clinic and I am talking about some of my OCD symptoms, but I'm also maybe talking about some trauma. And I maybe meet diagnostic criteria for PTSD or maybe an eating disorder, or maybe I'm really having some emotional regulation difficulties. And how would I figure out what treatment I should do? Like, do I still just do ERP alone?
Yeah, so one of the big things that I think is so important, real quick before I answer that, is like, as a clinician, if you go and see an OCD therapist, a therapist specializing in OCD, all of us have to do what's called continuing education credits, and that means that we're consistently going to different trainings, conferences, etc., and we're learning about the latest research, the latest data. My Master's of Science program was very Hopefully, right? My Master's of Science program was very heavy on research and evidence-based, and I even shout out to Dr. Abramowitz. I used some of his research in my thesis, but my point is we should be up to date on the latest. And when you go and see an OCD specialist, we eat, breathe, and sleep this disorder, and we're learning all the latest, and we're making sure that anything that comes into our space is backed by science, is backed by evidence, has been trusted and trained and rolled out and all that good stuff. So if somebody comes to my clinic and let's say they're dealing with obsessive compulsive disorder, maybe they also have a diagnosis of borderline personality disorder, and they want to get treatment only with me. And they're like, okay, ERP is working with OCD. I'm going to use ERP for everything. Exposure and response prevention is that gold standard treatment for obsessive compulsive disorder. With all of the evidence that we have, this is the treatment that has worked for most people, and it's the place to start for every individual with OCD. However, dialectical behavioral therapy, or better known as DBT, is the go-to therapy for somebody with borderline personality disorder. If you have a clinician that is absolutely versed in both, and I'm not talking about really versed in one and then read a book or something on the other, but is really going to continuing trainings, is reading up on the latest, they may be able to treat you with both, but they wouldn't use one therapy for both. They would kind of switch hats and use the different treatment for the other diagnosis. So that's why we do those different diagnostic tools, to really try to uncover what it is the client is dealing with, so we can give the right evidence-backed treatment for that specific disorder. Typically, what usually happens if the two diagnoses are so opposite is you might have a team, right? A treatment team. So I might work with that client for OCD, and they may work with a therapist who specializes in borderline personality disorder. And then we would collaborate care to make sure that person is moving forward and reducing symptoms in both cases.
Totally. Yeah. And there was a comment here that I think is really great for us to just touch base on. It was at 11:05. It said, "That's interesting. I've always thought that people with OCD who've gone through treatment have a pretty good idea of what the right treatment choices are." And I want to just answer this, is that I think that those of us that go through treatment and have successful treatment, we do actually know what the right treatment choices are for us. But that doesn't mean it's the same for other individuals, right? One of the things I always talk about, and I don't know what your thoughts are on this, Jon and Chris, is that when I was a patient with OCD before I was a provider, I didn't understand how to assess for other diagnoses, how to assess for comorbid conditions, or listen for things that I needed to be listening for to see if it might indicate another treatment would be recommended, or that there's something else going on. And so I probably blanketly, anyone who presented with what I thought kind of sounded like OCD would have said, "Oh, you need to go get just ERP," or "Here's the treatment that worked for me, so it'll work for you." And now I know, like, that is not the truth, because many times people have different things going on, but I didn't know how to assess for it because, again, I wasn't trained in that area.
Yeah, that's a really good point. I think another interesting phenomenon is that, when you have a problem like really any, let's just stick to mental health disorders, when you have OCD, or maybe you have depression or an eating disorder, what's often common is for people to go and do multiple, try to get help multiple ways: psychotherapy, medication, maybe they change their diet, maybe they take, supplements, all sorts of different things. And then maybe a little bit later, hopefully you get better. But people on their own, they would have a hard time kind of saying, well, was it the medicine? Was it the therapy? Was it the change in lifestyle? And all of those things may contribute differently to a person getting better. And so, anecdotally, if I say, well, I did this and this helped me, really, again, that's a judgment call. And it's hard for a person to kind of, decipher out what actually was having an effect or what combinations of things. And that's where we look to the science and the data that tell us, well, okay, we know that, these sorts of medicines and these sorts of therapies work for depression or OCD. But, when you take this kind of medication supplement, that you're, whatever plant supplement, that doesn't have any evidence for OCD. And so again, looking at the data is a different way of trying to figure that out. Again, as I said, apples and oranges, personal experience is important, not in the same way that scientific data are important.
Yeah, I mean, and I think the big piece is that those of us with OCD who have lived this, a lot of us are really fired up about it because we've gone down the rabbit holes of what someone has told us that isn't evidence-based, and it proved to be not successful. And then it's like you get more frustrated, you get more burnt out. Really, it's like, I actually went through this morning with a friend who was saying, oh, I gave this person a couple of recommendations. And I was like, oh, like, I wouldn't give them that one recommendation. Like they don't do OCD work at all. And it's like, oh, wait, what? Like, but they wouldn't treat them if they don't do OCD work, right? And I was like, no, we'll still, and I hate that. I hate about our system that it is so hard to figure out what to do and where to go. And our goal is that these quick little videos might make a difference in that. And so, Luby, reading your mind, because you asked if we can talk about where a patient starts, how do you find the right provider with the right training? And my next question on our outline was, how do we know where to start? And how do we find a provider who's qualified? So let's jump in and get started there. So Chris, we'll start with you. How do patients know and where do they start? What do they do first?
Yeah, so what I always strongly suggest, so I run a family and loved one support group. We have like 100 families that come from all over the globe, and they're asking that question. What I always say, I mean, the IOCDF has a good searching tool. It's iocdf.org/find-help, and they make it very clear that they don't vet everyone. You can't vet people as a nonprofit. The hope is that people that put their information up there means that OCD is one of their specialties. But what I really tell people, if they have that kind of availability in their area, is look and find a licensed provider who is a therapist who's licensed in that state. And then what you want to do is find out, do they have a specialty in OCD? You may go to a general doctor if you're feeling a little sick, and that general doctor is then going to prescribe you to a specialist, maybe an ears, nose, and throat doctor, et cetera, correct? So what we want to do is we want to find somebody who specializes in OCD. The way that you can find out that they specialize in OCD is a lot of times their website is going to give information. If they're listing a multitude of disorders that are not like an OCD and related disorder, so they're talking about trauma and personality disorders and couples therapy and career counseling, that person is slicing their OCD education amongst a multitude of different disorders, and you want to work with somebody that only sees OCD or is the majority. So I know like Liz, for instance, 100%, right? OCD and related, myself included. I see OCD, BDD, and related disorders, that's it. So when you find someone who specializes in it, that means that they've been trained in the therapy. I know the IOCDF has the Behavioral Therapy Training Institute, or the BTTI, or other institutions like that have done training, and you want to find out what is the background in that clinician. Have they sought out specific training to treat OCD? Have they been supervised by somebody in the field when they were acquiring their hours and specialized in OCD? Is that what their clientele mainly is? And then I would say, lastly, we know what works for OCD. We know that it's exposure response prevention, it's medication. Sometimes there has to be some adjuncts in there, but you want to make sure that that therapist is very clear on that. If you need medication, they'll refer you to a prescriber that really specializes in medication for OCD, and them themselves have been thoroughly trained in exposure response prevention and are going to start there. So that's really where you want to start for care. Lastly, you want to make sure you get assessed from them. Typically, it's using the Yale Brown Obsessive Compulsive Scale, and you want them to let you know the level of care you may need. So somebody like Liz, who runs a residential, if this client can't eat, can't sleep, can't function, they may need to go to a residential. So level of care is important as well.
So Jon, Chris talked a little bit about how, like, where they can start to find some providers and what are some of the keywords to look for. But how do we know if a provider is qualified? I want to really break that down of like what would make someone say both when they're first seeking someone out, but also when they start treatment, what would be some good ways for them to say, okay, this is a good fit, this person is the right provider for me?
Yeah, well, I mean, I want to go back to something that Chris mentioned and that is popping up in the comments is if they've been through training in the BTTI, the Behavior Therapy Training Institute through IOCDF, then they have not only attended a weekend workshop, and you need more than just a weekend workshop to be good at treating OCD, but then they have worked with folks who have OCD. They've been supervised, kind of supervised, but they've checked in with a consultant, and they're serious about doing this. So that really is, I honestly think in this day and age, that's the best way to find someone and to know as best that you can. But other than that, the feeling that you get if the person kind of understands the experience that you're going through, can they seem to relate to the intrusive thoughts that you're having? They don't have to have had it themselves. You don't have to have OCD to be good at treating it, but that they can kind of understand and ask questions that seem to make sense. That kind of gives you an idea that they get it. OCD it's not easy. If you're not trained in it, it's not easy to understand, that my thoughts about harming people don't mean that I need to, go to the emergency room or anything like that. They're just senseless thoughts. And you need to be sure that the therapist really understands the intrusive thoughts, how compulsions are related to intrusive thoughts, how the whole vicious cycle of OCD works. And so making sure that what they're saying, that you're connecting with them on that level. I hope that answers your question, but not everybody knows how to do that. There's so many therapists who say they treat OCD, and as we've been talking about, they don't have that kind of training. They don't have that understanding.
So the last question I want to ask around this before we jump into treatment is, the next question is kind of what to do and think about if our current treatment isn't working, but how do we know if we're in the right treatment? So I think that's great. Like, we have a good understanding so far of how to find some providers, and then how to assess if our providers might be good. But what should we expect, right? I mean, the literature tends to tell us 12 to 16 sessions, but I would love to hear more from a current research perspective that's probably outdated. When should we say, like, okay, this should be working, or we're seeing a difference and this treatment is on track?
Yeah, in most of the studies, 12 to 16, in some cases 20, sessions. But also you should be getting, homework to practice between sessions so that you can really make the therapy as intensive as possible. You want to be not only doing exposure therapy with your therapist in most cases, but also practicing, every day in between sessions. And if you're doing that, then seeing improvement is possible within, a month, give or take. When people start to do exposure therapy and they stop white knuckling through their obsessions, and instead they kind of work on practicing leaning into it, they learn a new relationship with their thoughts. They learn to not be afraid of certain things. And consequently, they're able to open up, and do more things in their life, which is, I think, the most important outcome. And people start to see that once you're doing exposure and response prevention relatively soon. It's different for everybody, so I hesitate to say, after 6 weeks, you should see a difference. But a lot of the folks I work with, after 6 weeks, they're seeing a difference.
Yeah, if I could add to that, I would say the difference that I feel like this therapy really is, because a lot of my friends are therapists as well, but they treat other ailments. And the difference is, like, when you're working with a psychoanalytical therapist, I mean, you're bringing up stuff from past childhood, you're looking at attachment issues. There aren't clear-cut goals always. I mean, the person wants to feel better, they want to get more insight in their past and decision-making, but an individual may have a psychotherapist for 7 years, 10 years, their whole life. OCD is a much more solution-focused therapy. So what I tell people, because people ask me that question all the time, how do I know if I'm right with the right clinician? You should be tangibly seeing a difference. So one thing I always do with my clients is I ask them at the first couple sessions, like, how would we know you're getting better? What are some things that you really miss out on that you would be doing? And they might say, oh, driving, cooking my own food, spending time with my niece and nephew, etc. And so I make exposures around those goals that they have. And we should start to see, like Jon was just saying, after a month, a 2 month, I mean, the client should definitely see a reduction in symptoms. They should see an expansion of life. They should see themselves back into the things they care about. And each kind of like every other week or each month, I'm kind of doing a quick check-in. We should see forward momentum. Once again, if we're doing all that and the client is either not engaging or they need a higher level of care or medication, that's kind of, those are kind of some different things. But typically, like Jon was saying, if you know you're with the right provider, you should be seeing results. That's what's so great about this treatment is you will start to see results. You'll see your life open up and things will get easier.
Totally. So let's hop into the next questions. What do we do if treatment is not working? So if what we find is that so these are kind of like, how do you know when it's working and when you're with the right provider? But if we find it's not working, so maybe we're not seeing good outcomes, or maybe the needle isn't being moved. What do we do? What's next? Do we assume therapy doesn't work for us? Like, what are people's thoughts?
Yeah, well, I think the first step is to try to figure out what's going wrong. And there are a number of different things that could be going wrong. The person might have, if it's someone that has serious depression, they might feel kind of really bad about themselves and feel like they don't deserve to get better sometimes. And that can interfere with exposure and response prevention, with doing ERP. Exposure and response prevention is a challenging, difficult treatment to do. It's not just kind of sitting around and talking about your potty training and stuff like that. You got to get up and you got to do stuff. So problems with depression can get in the way. People are often really, really afraid. And so sometimes therapists try to move too quickly. Sometimes the person is just not at a place where they're ready to face their fears. That can get in the way. That doesn't mean the treatment doesn't work. It might mean the person isn't at a place where they're ready to do it. So there might be factors related to the person with OCD that are getting in the way that maybe need to be addressed first. There also might be factors related to the environment. And I see there are a couple of comments on here about family accommodation, and family members sometimes will step in and do things for a person with OCD, accommodate their symptoms, which can then make it harder for treatment to be successful. Maybe we can talk about that later. And then finally, it can come down to the therapist just not, implementing the treatment properly. And so for the first thing is to understand, what might be causing a problem, maybe getting a second opinion if things aren't going well, to try to figure that out. I'll stop there. I got more to say, but I'll let Chris jump in.
Yeah, what I was going to add is typically if the ERP isn't working, I always think like there's a lot of things you can do as a clinician before you just give up. So a lot of times I'm going to make sure that a client has enough psychoeducation that they really understand how the OCD is impacting them, and then what we do as individuals with OCD to kind of exacerbate. So, when I was struggling with OCD, I was constantly checking out in my head, ruminating, right? So kind of really getting a client to understand. And then as a clinician, we should know what pace to go. Sometimes therapists are pushing a client too quickly, or they're choosing exposures around things that the parents want them to get better at and not really something that they find of value. So I always kind of start there, the right pace. Why is this person here? What do they want to see? Let's do exposures around that. Jon touched on it. I'm making sure that family accommodation isn't present. It's really difficult for a client to get better with working with me if they go home and the parents are enabling all the time. We got to also make sure is like there's a type of intervention known as motivational interviewing that was originally designed for substance use, but now there's a good article on how to do it for OCD. So I'm checking in on motivation. Where is this person at? So I'm making sure all of those components are happening. Do they need to be on medication? So we're having them go see a psychiatrist and we're collaborating on care, kind of getting family in there. What can we do to set up the environment better? So, I'm also making sure that it feels very collaborative. So the client feels like they are participating in it and they have kind of stake in the game. There's also an adjunct treatment known as acceptance and commitment therapy. It's a type of adjunct that can really help frame ERP in a values, goals-based mindset. It teaches someone acceptance of thoughts, a commitment to values. And so a lot of clients really open up to that. Support groups are incredible. I see a lot of my teen and young adult clients that might be on the fence about getting better, meet others who have gotten better. I show them live streams like this. I think sometimes, as long as it's not compulsions, but mindfulness-based CBT sometimes has some really good adjuncts in there that I use. So there's all these different tools we have. I don't seem to have the issue that clients just don't get better. I think if all of those things are happening and someone's still not getting better, typically what I recognize is they need a higher level of care, whether it works with Liz or works with a different higher level of PHP or a residential. I see them really make strides, and then they might come back for some outpatient and consistency in care. So I see that there's all these different options we have, and I see a lot of people get better.
I do want to jump in for a second and just say that, Chris, I love you, and I think that any patient would too. But I think it's important to recognize that besides, there's certain providers that you might click with versus not. And I think the first thing too I wanted to say is that it isn't just about ERP. It's also about the therapeutic rapport and relationship, right? If I don't trust Chris and I'm working with him, I have to do the ERP he's telling me to do, right? And so a good provider should also be building rapport. So don't just automatically assume ERP doesn't work. And it doesn't work for me if I went to a provider who said they did ERP. It could be that you didn't have a strong relationship with them and that you didn't have that first foundation to be able to even do ERP. It could be that they're not effectively qualified in ERP. A lot of people say they treat OCD or have ERP background, and you don't click with them, or they don't use approaches that make the most sense or that are correct. And so I also don't want you to give up if you've gone to one provider and then just say, okay, it doesn't work. Try another provider who specializes in ERP and see if there's a difference. Because we see that all the time, Chris. I know you and Jon see that all the time too, where someone didn't have great success with someone else who maybe even the three of us are good OCD providers. One person doesn't have as good of success with one of us, it doesn't mean they might not with the other two, or that ERP for sure won't work.
Well, really well said. Yeah, real quick, I just want to add to that. Well said. I mean, I work at a group practice, and there'll be a time where I get a client who's like a 12-year-old, preteen. Her OCD is all around kind of like body function stuff. We have female clinicians at our clinic. We have young female clinicians at the clinic. That might be a better fit. So I think that's one responsibility and ethical responsibility for us as clinicians, is if we're sitting with a client and we know that there might be somebody else that we know in the area or in our practice that might have a better click, that might work. And sometimes that is the difference. I was working with a client who's in their 80s, and at the time our clinic had a clinician who was a lot older. And the client was telling me, he's like, it's really hard for me to listen to you, man. You're like the age of my grandchildren. So they ended up moving to the other clinician, and they just got it. They reminisced about stuff, and next thing you know, he was willing to listen. So great point.
Yeah, and just to go back to Liz, what you were saying before, I think behavior therapy and certainly exposure therapy often gets a bad rap for being kind of like cold and all that, but it's not. A behavioral therapist, an exposure therapist, you want to think of them like a coach, and any sports player or musician knows that in order to get the most out of the coach, you develop a close personal working coaching relationship with that person. So like you said, so you trust that person and you know that person's looking out for you. And believe it or not, we do have that in behavioral therapy. That's such an important part of treatment, because I can't get people to face their fears unless they trust me, unless we have a relationship. That's so important.
Right. Yeah, no, totally. And I think so. Jeff Szymanski, the executive director of IOCF, always talks about this, how actually like rapport is first. Oftentimes we think it's ERP, but it's not, right? We're asking you to face fears, to quit avoiding things that you've been avoiding for years, sometimes, decades for some people. Of course you're not going to do that if you don't trust me, and so a lot of that is built in together. One of the questions that we got asked that I want to talk about, because I think that this is really important and it can happen, is, what happens when you find that your provider is kind of, there's some, it feels like there's empathy fatigue. So one of the questions is like, if a provider is like experiencing empathy fatigue, or like you're feeling that, right? So you're feeling like your provider maybe is like burnt out or frustrated, or they're not really connecting with you. What do you do? And why is that really important? I think this is like exactly on topic. What we're talking about is like, what if the connection was good, but it's starting to waver? Like, can you have a conversation with your provider about that? What should you do? And what as a provider would you want your patients to do if they're experiencing this?
Yeah. Go ahead.
Yeah, no, what I was going to say is one of the things that I wish I knew as a consumer of treatment. I was very fortunate to love my therapist and have a good relationship. I also saw them as like a pedestal above me. And I think if I would have been more open at times and it was nothing that they were doing, if I would have understood that the power dynamic is not teacher-student, I might have spoken up on certain things, but it ended up working out. But one thing that I think is a responsibility for all of us as clinicians is it's never the client's responsibility. It is us as clinicians to provide a space that feels open, safe, and comfortable enough that the person can ask questions. What I try to do is I try to tell everybody in the first session, like, I don't have an ego about therapy. Please let me know if I'm not doing something right, if I can be a different way for you. I also understand that that still may not be comfortable, so I try to check in throughout. But if you're somebody who's in treatment, please trust that clinicians, I can't say all of them, but most of us have gotten trained and beaten in our heads that we have to adjust and it is our responsibility. We will not take it personal. So please feel confident to talk to your clinician if there's something that they're doing. If you're feeling that they're fatigued and not showing you empathy and support, ask that. I also think as clinicians, it's our responsibility if there's something going on that we get consultation, or we recommend that the client maybe works with someone else if we just have hit a wall. But I always think that's on us as a responsibility. But yes, as a client, please feel comfortable to open up and have a discussion with your therapist. It's important.
Well said.
Well said. Next question, we could all keep adding, so I want to keep going, is when do we consider intensity of care? So Jon, if you'll take this one, but at what point, if we're working, we have good, so if we have good rapport, we are working and we know that like we're trying, but the needle maybe isn't moving sufficiently, but like when, at what point do we say, okay, maybe we need more than outpatient?
Yeah, I think that if a person if they're struggling with resisting their rituals, that's one of the first things that I find. It's not just exposure. You got to do exposure and response prevention. And if you don't have response prevention in there, the person is not going to do well. And so if they need a higher level of care, for example, a residential program where they can have staff on hand, 24/7 to help them to resist urges, in the middle of the night to wash their hands or check or things like that, because they can't do that on their own. Just having that extra supervision, that's one of the things that I look for. Then also folks that are having trouble just kind of managing like with daily activities of living, getting themselves ready and self-care, hygienics, things like that, hygiene. That would also be an indicator for me that it's time for residential care or, some sort of higher level of care.
Yeah. And what I want to say is that as a clinician, we really, in the clinical intake, right, the first thing we do with a patient, we should get a good inclination if what level of care this patient might need or that we think is warranted. And if we're pretty clear that due to severity level, we're not sure outpatient is going to be sufficient, I want to be talking about that at day one, right? And it doesn't mean we may not give it a try, but I want to be honest with you to say, hey, Chris, like, here's what I'm seeing. Your level of severity is really more in the severe to extreme range. And so while we can give outpatient a try, I want to be candid that it may not be the appropriate level of care for you. And so let's make sure that in a week or two, we're really continuing to discuss if we think this is the right fit, right? It is our job ethically, if we're a good clinician, to not keep you on our caseload if we're not the right fit or you need more, right? That isn't fair to you. You're going to not believe in treatment. You're not going to get the outcomes you want. And it prolongs your suffering, right? Versus getting you back to life and to the things that you're in treatment from to begin with. And so I want to push that a little bit. The second piece I want to say is that, across the board, one of the things that I think is really important that Dr. Abramowitz just mentioned about the ritual prevention is if homework goals that are being set are something that you almost can never achieve, it is really important that you talk about that. You should be talking about, are the goals too hard or what's going on? Because that is the indicator that you need more support in between sessions, which would also indicate a higher level of care, right? Because you're struggling to do that work independently. And we know outpatient care requires mostly independent work, right? You're only coming into the office once a week, 45 minutes on average. The second piece I'd love for you to tackle is, how does medication play a role in all of this? And what should patients be doing when they're engaged in effective OCD treatment? What does medication look like? How do they find a good psychiatrist that can treat OCD? Should it be collaborative with their team?
Well, I'll jump in. Yes, it should be collaborative. So there are medicines that have been approved for OCD. They've been studied. And I'm talking about the serotonin reuptake inhibitors, the SSRIs, selective serotonin reuptake inhibitors, but their effectiveness can vary. Some people swear by them, they take the medicine, they feel better, and they're doing great, and they continue to use them. That's great. For other people, they don't seem to make a difference. Most people, it's somewhere in the middle. The downside of medication is that you got to continue to use it in order to keep, doing better. And now we're seeing some more scientific data kind of coming out, kind of questioning about how do these medications work, and some things that we could get into maybe another time. And now I'm forgetting your original question. Oh yeah, right. So, but you do want to make sure that your therapist knows that you're taking medication, and that your psychiatrist knows that you're also doing the therapy, so that there can be some coordination around that.
Yeah, totally. Yeah. So it's what we know is it's often the most effective treatment is a combination of medication and therapy, but therapy is really the piece that has to be happening. And that is something, it's a tool you get to use the rest of your life, right? Once you learn it, you get to keep using it. And yes, I will take you on your second offer. I don't know if it was a full offer, but I'll just make it an offer where we would love to do a medication talk, and we need to do one, Chris. That's overdue for a lot of our questions we've been getting. So we'd love to bring on you, Dr. Abramowitz, talk about research, and then a psychiatrist to talk about current medication, and that will be great for us to do. So the next question that is might get y'all fired up. So I'm going to just give you a quick pre-warning, so take a deep breath before we answer. What roles do alternative treatments play for OCD? And I want to talk about that. And the question I wrote is, why or should somebody ever consider an alternative treatment versus thinking about more intensive ERP, or maybe ERP with a different provider? I think a lot of times what I'm seeing a lot in the field, and this is why I say we might get fired up, is just because we all have different thoughts about it. But I'm seeing a lot of times of like, okay, I went and tried ERP with Chris. It didn't work for me. It didn't help me. Therefore, ERP doesn't work, and I need to go do this other treatment instead. That's not really what research and science and our knowledge of OCD treatment would tell us right now. And so you guys tell me why you may or may not recommend that, what that would look like. So what should it look like if ERP doesn't work? Do we consider alternative treatments right away? If so, what do those look like? How do we navigate all of this knowledge and all of these new concepts, new modalities that people are throwing out there that we're hearing about? How do we know what to choose and to navigate that?
I'll let you go first, Jon, and then I definitely obviously have an opinion too.
Yeah, sure. Well, the first thing I would say is that my sense is that, unfortunately, there are a lot of people with OCD and their families, and clinicians who say that they treat OCD, who are afraid of exposure, who are afraid of having their clients or themselves, do things that are going to provoke anxiety, and they have kind of a negative reaction to the idea of exposure therapy. They think it's cruel. They think it will have, some sort of long-lasting negative effects. Those things are not true. Exposure is safe. We all do exposure therapy in our daily lives anyway. Anxiety is safe and normal. And so I would not, generally speaking, I would not steer people away from exposure. The work that I would do would be to help them get to a place where they feel more confident in trying to confront their fears. We have the best evidence for the effectiveness of exposure and response prevention for OCD. It's not clear to me why someone would do another therapy before all opportunities to do exposure have been exhausted. That doesn't mean those other, there are other therapies that have been studied, but I would only use those absolutely as a last, resort.
And correct me if I'm wrong, right? We're talking about for OCD, right? So again, if someone comes and presents at our clinic and they're dealing with OCD, but like they also have a diagnosis of, let's say, BPD, and they're experiencing a lot of emotion dysregulation, really a lot of difficulties with that's preventing them from being able to do ERP, we absolutely should be saying you might want to consider maybe you call it alternative to ERP, but really you might want to consider the evidence-based treatment for emotion regulation and distress and tolerance first, right? So maybe you should do some DBT work first.
That's right.
Then we will have a stronger chance at ERP being successful for OCD. But what I want us to hear is that the biggest question I want you to ask is why. If ERP for your OCD is not working, instead of just throwing it away and jumping to something new, since we know that has the best chance of it working, can we say, why might it not be working? Is it because there's something else going on that needs to be addressed? Is it because our provider and I didn't have a good connection? Is it maybe because we didn't have a provider who was that well-versed in ERP, even though they said they would, and maybe we should try a different provider? Think about all the different reasons before we just say, we're gonna, throw the baby out with the bathwater. I know it's not a good analogy, right? But like that thought process, because really, like, we know ERP is incredible. But Chris, I know you wanted to add to this.
Yeah, so I get a lot of people, whether it's because of advocacy or, just being in the field, I get so many people that reach out, usually parents, and they'll say, my loved one has tried ERP, it did not work, what are other options? What I always say is I will absolutely support you, but I need to talk to your loved one first. Maybe it's anecdotal. Thank you, anecdotal. Maybe it's anecdotal, but when I have a conversation with that person, it has never been that they have seen a provider who is trained in ERP and they did it well. A lot of times what I'll hear is I could tell that this is a clinician that must have just read up on it or something. First session, they're, licking the bottom of their shoe without getting education and stuff. And so when treatment can feel like fear factor to people, sure, they're now going to have this idea that ERP is fear factor. Why would I put myself through it? Often I'll talk to them and find out, I'll be talking to them and they're like harshly using drugs and alcohol. So it's like, okay, that may be something that interferes. What I'm always confused when people say ERP doesn't work, I'm like, how can it not work? If you do like values-based exposure, if I love my nephew, I never had intrusive thoughts about my nephew, but I know a lot of people do have intrusive thoughts about minors and loved ones. If I had intrusive thoughts about my nephew, how could the way to get better not be that I have to spend time with him? I have to regain that connection because it is such a big part of me as my role as an uncle to be around him. So I always get really confused when people are like, ERP just doesn't work, I got to find something new. But like I said, when I talk to them, I hear that there's comorbidities that never dealt with, that ERP wasn't properly explained, it was rushed, it was done with a clinician who treats multitude of things. And so then people are looking for things like EMDR, tapping, psychodynamic, they're looking at TMS and no behavioral component. I also think lastly, a lot, what Jon said, a lot of therapists come from such a like Carl Rogers humanistic background. And there was a study that I think NOCD did where they said that most individuals with OCD are okay with ERP. It's the clinicians that are scared. And I think it's because they come from a like holding the space background, and it seems cruel and harsh to see a client struggling and in a little bit of anxiety, but the client is regaining the very thing that they lost because of the disorder. So as a clinician, if you're going to work with this population, just like if you're going to work with addiction, you got to be stronger than the client. Like you can't go in being afraid and scared and then saying, I'm going to look for a different treatment as a provider that's softer and kinder, even though there's no backing to support it or not enough backing to completely ditch what works and jump into something else.
Two things I want to say. Number one, in school, we don't really learn when we're going through, unless you get great training at certain OCD clinics, right? We don't really learn that one of the biggest parts, actually, of being a really good clinician is sitting with distress and just learning how to tolerate other people's distress and being okay with it. And that is actually one of the most important pieces as a clinician, right? And I hear this all the time because I'm at a clinic where we have a lot of residential counselors who don't have the training and background who will say like, you want me to just watch them super distressed? What am I supposed to do? And I'm like, we just sit there with them. And they're like, what? Like, why? I need to fix it. And I'm like, because it feels opposite of being a human being, right? Being someone who cares. It's like when my daughter's crying, I want to pick her up and hug her, right? And my husband is better at being like, you're fine, get up. Olivia, like, we're not doing this right now. She's into this new bizarre phase, you guys, where she puts her head down and just bangs it on the ground. I'm like, what are you doing?
My little sister did that, yeah.
My response is like, you're going to get brain damage. And he's like, ignore it. She's fine, But what level of distress. We are learning to tolerate distress even as clinicians.
And in this day and age where, especially I think in our society, we're all about like safe spaces and protecting everyone from any sort of anxiety or any sort of distress. And I get it, that's coming from a good place, but people are not that fragile. People with OCD are not fragile. People with OCD are stronger than most people because they live every day with anxiety. They can do it. It's a matter of helping them to experience that distress in a healthier way rather than trying to white knuckle it and push it away.
Right. It's what are we teaching ourselves? And what I'm trying to teach you is that anxiety is not dangerous and we have to quit acting like it is. And so as a clinician, I also have to believe that and know that, because if I start to feel distressed when you're experiencing distress, that's not going to be a good therapy session, right? If I'm like, okay, well, just maybe kind of touch that, right? Don't, it's okay. No, it's like, hey, yeah, let's do it together. We got this. Number 2, talking about myself, sorry to do so. ERP that I received ERP from, in my opinion, and I know I'm biased, some of the best clinicians in the world. It didn't work for me for 10 years. For 10 years, I was somebody that could have said to any of y'all, ERP didn't work for me. But it is not because ERP didn't work for me. It is because I wasn't ready for ERP. I wasn't willing to experience the distress. I wasn't bought into the treatment model. And I was halfway doing ERP. I was 1 foot in, 1 foot out. I was doing ERP in a way that okay, I'll do it enough to function, but I'm not actually willing to face my fears. And so my outcomes because of that for many years were marginal. I can remember I would see Grayson at the conference and I always thought, is he like a psychic or what? It's so weird because I'd be, dressed and fine and presenting and he'd come out to me and be like, so when are you going to start leaning in? I'd be like, what are you talking about, Jon? And he's like, I can see OCD. And the reality is that I would have been this is why I'm so passionate about this area. I would have been one of those cases where we would have said ERP doesn't work for Liz.
Right.
But it was because I wasn't accepting the ERP model. And when I finally said, okay, I am willing to really do ERP and give this a chance and get rid of my safety nets that OCD wants me to keep, that is when I saw success. And so I'm passionate about us talking about this. Ethan talks about it too, that many times when we're like, oh, ERP didn't work for me, it's like, wait a second, ERP did work for me, but I needed to get ready for ERP. I needed to be bought into ERP. And so be careful not to just write it off and instead to say, why isn't it working for me? And there are many people where we need more. And there is a lot of other options, right, that we can think about. Dr. Goodman always says, and I loved my work with him, is he always said, we are never at a last resort. There is always more we can try, different things we can use to approach OCD treatment or your diagnostic picture. But I want you to sit back and say, if something isn't working, why, before we just throw it away.
Wow, yeah. That's powerful. That's like the greatest thing I've heard in a month.
Yeah. No, I mean, absolutely, Liz. And obviously opening up and sharing and being so candid is why, advocates are needed so people can feel that way. And I just, when you were talking, I mean, the reason that I'm so passionate about this too is what you just said, because I think about it, like, what if you would have just given up? What if you would have tried other things? You wouldn't be where you are today, right? And I know for me, I was ready for treatment. I didn't have to get ready because I just came off of a suicide attempt, a hospitalization. I was at the lowest. And then we went for 1.5 years of OCD therapists. And what did they do? They sat there and they talked to me about the OCD. And I would just go in and it would be a big reassurance session and I'd leave. And the second I was in the parking lot, I was back to doing compulsions and I was in the car for like 3 hours before I left the office. So then I was hopeless and I was ready to give up. And then that's when my mom found the IOCF, and I was lucky to immediately find somebody who specialized in this treatment. And I was in a mental space to be ready. So what I always get nervous about is like when people are trying to push other things, what I get worried about is like, I did that for 1.5 years, like just fresh off of a suicide attempt. If I didn't have my mom, and that's why I will be forever grateful, kind of like being there with me through that 1.5 year journey, I could have attempted again. I could have given up. It wasn't until finding somebody who is trained in this treatment and gets it. And so when we push people away from the treatment, that is the most studied, the most researched, and helped. I've never met somebody who's gotten better from OCD, by the way, who hasn't done ERP, right? It also can put people in the position. I know, you know what? I really want to yell that from the rooftop to any clinician that talks about ERP doesn't work. I'm going to try this alternative. I talk to more people with OCD than I talk to my family on a daily basis. I have never come across somebody that said ERP didn't work. I did this thing. I am now super recovered. I'm subclinical and I'm living the best life. Yeah. Why would we turn people away from what has helped everybody I've ever met in 12 years of advocating to something else?
Now we do have a biased sample because in our profession we're only seeing people who are seeking services and all that. But that's a really great point. I come
always in the advocate sector, right? Like
I see people everywhere.
That's right. You guys see. That's right. Yeah, you have a different, and it's kind of related to what I was going to say. I come at this from a different angle, as someone who is a psychology nerd and studies behavior and all of this stuff. It's been 100 years, since the 1920s, literally, since we have data that exposure for fears, and OCD is a fear-based problem, doesn't matter where they stick it in the DSM, it is a fear-based, anxiety-based, disorder. We know that exposure works. We know the behavioral principles. They've been worked out by people like Skinner and Pavlov and John B. Watson 100 years ago. So, right, it doesn't make any sense to say that exposure won't work for me. It is more a matter of, are we doing it properly? And there are, as we've talked about, there are plenty of things that can get in the way of doing it properly, and it's no one's fault, and we don't want to blame people for that. But this stuff works. It is a scientific fact that if you are afraid of something and you're doing rituals to try to, make yourself feel safer, and instead you drop the rituals and you face your fears, you will overcome your fears. It's just the way that our brains work.
Yeah. So the two questions to ask if ERP isn't working is, am I with the right provider? Am I getting the right ERP? And the next question that I'm pushing you to ask is, am I actually giving ERP a chance? Am I leaning in? Am I doing it all the way? Or am I kind of doing it hoping for full outcomes? The last piece that I wanted us to talk about, and I know we got a lot of questions that we probably won't get to, but Chris and I will either answer those next week, or of course, as always, we will do recorded sessions where we will get to these because these are such great questions. But I want to make sure we cover the last section, which is, what should we expect from treatment? I want us to talk for a little bit about what we should expect to say, okay, ERP was successful. What does that look like? And I'm super passionate about it. And let me go back to why. For me, I spent many years of my life. This is when I'm saying I was one of those statistics that could have said ERP doesn't really work, where I truly believed that treatment from OCD meant that it might get me back to functioning. And I really did think that the best I'd ever have, right? I was accepting a life that my best chance or my best outcome would be that I could function in life while still living with, suffering with OCD. And it is a message that I think advocates have incorrectly given for many years, where when we're in the middle of our throes of our struggle and we're advocating, that's great because it helps people see that they're not alone. But it also sends this message that that's what you should expect forever. That if you have OCD, you have this chronic disorder that you're always going to struggle with. That is not our goal. Chris and I and John, we'd have a pretty miserable job if we were working every day to get you to function and struggle with your OCD versus working to get you to freedom. And so I want to talk about this quickly because I think it really makes a difference in what to expect in treatment. And what I mean by that is, one of the things I wrote down are two things. One that Chris always says, which is treatment as a lifestyle is not a dreadful daily choice. This is not fear factor. Number one, it shouldn't feel like this exhausting, dreadful experience and fear factor. It should actually feel exciting that you're getting your life back, and you should be proud of yourself, and it shouldn't feel horrible and dreadful and scary. If it does, we're probably white knuckling versus fully engaging in treatment. And the second is that treatment should not mean that forever I'm going to therapy every single week and talking about my OCD struggles from the week. So that's always a red flag for me. If we're doing ERP, but what we find is that we've been in treatment for 2 years and every single week we're saying, okay, here's my current triggers and here's what I'm currently struggling with. And Chris, how do I get through this? Then we're not really buying into the full concept. We're not living our life doing ERP treatment. I still go to therapy every week. Y'all know that. And sometimes it's some OCD stuff. I had a new sexual intrusive thought that was really intense, that is still kind of on my mind, even though I'm not ritualizing about it, around my daughter on Monday night, that is still kind of lingering, right? But like I'm continuing to face it and it will go away. So maybe I would talk about that a little bit in treatment this week. But this week in treatment, I'm going to talk a lot about my husband's career and anxiety and different things that we're navigating as a family and that we need to talk about. Because it's not, treatment for me is not every week, oh my gosh, here's my trigger, it's urgent, we need to approach it. That is not where we're living and doing ERP as a lifestyle. We're doing ERP for symptom management. I do not want any of you to think that ERP treatment means that we just learn how to, every day we're struggling and learning how to manage our current symptoms. ERP treatment should mean that you get freedom from your OCD. And many of you watching today are saying, BS, Liz, that isn't possible. I don't believe that. You can say that all you want. You're a lucky one, but that's not in the cards for me. I was there. Chris was there. I can promise you it is in the cards for you. And I get so passionate and excited about ERP because I know that it can give you a chance at having a full, free life where OCD doesn't have to make one decision for you. That is what we're fighting for. And that is what you should hope for with appropriate treatment. Chris, I'll throw it to you to wrap up.
Yeah, I mean, extremely well said. I think that that's something that you've talked about a lot. I think the two keys that I've been focusing on is A, what you just said, and then B, something that Jeff Schmansky's talked about is like treating the whole person. What we can expect from treatment is just what Liz said. It isn't about managing your symptoms till the day you die. What I really think about to simplify treatment is like when somebody comes into treatment, their world's gotten a lot smaller because that's what the OCD does. It asks you to control everything. And so what the treatment is doing is opening your world up. And you should be living a fulfilled life if treatment is done properly. So when I left treatment, I was still managing stuff, but I got back in school, I got back into work, I started dating and friends, and it just became a lifestyle. Anytime something came up, I went big, I went bold, and I went out there just to spite the OCD. And what pretty much started to happen is I felt like my life was full again. I felt like I had this like bump, and then I got back. And I think some of the things that I learned in ERP therapy still to this day helps me just in life. It's like we're going to always come up against fear. We're always going to come up against something that we are really uncertain and kind of scared about. And the treatment has taught me to lean in and to go for it and to trust myself and absolutely know that whatever happens, I'll bounce back and I can tackle it again. So the reason that we came together for this panel is we want to let you know not only is there absolutely good care out there. I know it's hard to find sometimes. Telehealth has made it easier, but it's still hard to find. But there are great treatment providers. You have a great resource in the IOCDF. And then lastly, from Liz and I's kind of personal experience, not only does treatment work, but it's not going to just kind of get you to sort of okay. You can absolutely live a fulfilled life. So lean in and absolutely give it a chance.
John, anything to wrap up with?
Yeah, well,
sorry that we lost you.
Yeah, my computer just decided to restart randomly. What was the question? Just wrapping up stuff.
We were just saying any wrapping up and closing points.
Oh, no, I mean, I think it's a great discussion how, this understanding what are the effective treatments, that's where it starts. How do you find a provider? This is, just a great resource for folks. You guys, I think we all share a brain on this call here.
Yes, and I love that. Well, thank you so much for joining, John and Chris. As always, it's been incredible. And I want to leave with the message that I truly believe and wouldn't be doing this work if I didn't, which is that we are fighting for freedom, not functioning. I don't want anyone to accept that treatment and ERP means you get back to functioning with OCD. We truly can achieve freedom from it, and that's what we're fighting for. So keep searching, never give up. And again, if something isn't working, figure out why. Let's work on approaching that. Thanks, you guys.
Take care. Thank you so much, John, for joining us.
Thanks for having me. My pleasure.
Absolutely.